Hello everyone, how's it going? Today we are going to continue our conversation over the control of cardiac output. And so we have previously discussed the effects on preload, afterload, and contractility on stroke volume and cardiac output. And today we're going to tie that in together with the pressure volume relationship that we have also discussed in the past. So we're going to look at those pressure volume curves and look at the effects of preload, afterload, and contractility on those curves. Here to the left, you can see this volume pressure loop. And first, we're going to start off with discussing how changes in preload ultimately impact this volume pressure relationship. And so hopefully you remember A through C is our period of diastolic filling. And then we get systole from point C to point F. Point D right here to point F, that's our period of ejection where volume is actually being ejected from the left ventricle. So now let's look at this middle loop as our control, as our normal, or starting value, our baseline, right? So, you know that point C right here, that's going to be our end diastolic volume, or the amount of blood that fills up the ventricle at the end of this diastolic period. And this point F right here, that's going to be end systolic volume, or the amount of blood in the left ventricle after the contraction and ejection, with points D to point F here. So when blood's ejected, this is the volume of blood then left over after that contraction. So let's say we have a decrease in preload. We're going from point C here. A drop in preload is going to bring us to here. And so that decrease in EDV is ultimately going to lead to a decrease in stroke volume. And so we know that stroke volume is EDV minus ESV. So the lower the preload, the lower the distance between these 2 points. And so when you decrease stroke volume, you decrease preload, you decrease stroke volume, and then when you increase preload, we increase stroke volume. But we already pretty much knew that, right? And so you could see another impact from a decrease in preload is a decrease in end systolic volume. Why is end systolic volume decreasing? Well, that's because you started off with less. So if you start off with less blood, you're likely going to end up with less blood. So even though, you are ejecting more blood out as preload increases, well, you had a starting amount of blood that was higher, so that's going to increase the amount of blood left over. And so, that's good for then the sequential beats after that, right? Because that increase then in volume is going to help the amount of blood for the next beat and the next beat. So by increasing preload, we shift everything to the right, and by decreasing preload, we shift everything to the left. But you could tell that these 3 points line up on the same line. When you draw, this line from the x-axis here, these line up on that same line, and that's an indication that these changes are occurring not due to contractility, but due to changes in blood volume entering the left ventricle, that venous return. So, as we look at these volume pressure relationships today, if they're on the same line for ESV, this point F, that means contractility is the same. So overall, though, summarizing this here, a decrease in preload, we see a drop in end diastolic volume, we see a drop in stroke volume, right, as indicated by this graph to the right here too, but we see a drop in stroke volume, and then we see a drop in end systolic volume. And so we know that, a decrease in stroke volume due to a decrease in preload then decreases our cardiac output, and that's going to decrease our blood pressure, our mean arterial pressure as well. But, when you start looking at multiple loops together, you're really looking at the complete range, the single cardiac function curve. So basically, again, you're just looking at this volume pressure relationship as preload is adjusted, and this is the complete range. And so when preload is small, the heart's going to operate on this loop to the left here, and then as preload is increased, the relationship, the loop shifts to the right here. So ultimately, preload is going to have an impact on end diastolic volume, stroke volume, end systolic volume, and then cardiac output and blood pressure. This is a figure stemming from a study in 1975, and basically you have this relationship between left ventricular end diastolic pressure, right, and the amount of stroke volume that is ejected, right? So the higher amount of volume of blood and the higher pressure at the end of diastole, ultimately the greater the stroke volume. And you can notice these words are different, but ultimately we're drawing the same conclusion. And in this experiment, what has happened is that you have all of these control subjects, right? And then they are influenced with different, pharmacological agents, things like dextran, to try to increase preload, therefore increasing end diastolic volume and pressure. And what you're seeing then is an increase in left ventricular stroke work index, which is an indicator, again, of stroke volume. So what you're seeing is with pharmacological agents and things that help bring up preload, we're going to get an increase in stroke volume, and then things like nitroglycerin that are going to decrease preload and then decrease stroke volume, therefore, right? But you could see this curve, it starts to get, we get an increase as we increase preload, we increase stroke volume, but that slope of the curve becomes a little bit less once we start approaching the upper limits of this curve. But all in all, we increase preload, we increase end diastolic volume. That's ultimately going to increase stroke volume of the left ventricle. Now that we talked about the effects of preload on cardiac function and the volume pressure relationship, let's talk about contractility. A rightward shift is seen of the pressure volume loop when there is a decrease in contractility. Such would be the case in heart failure. So you're seeing less ejection of blood from that left ventricle. We'll break this down a little bit more here in a second. But when we have an increase in contractility, well, then we're going to see a leftward and upward shift of this loop. And so, again, when you see the end systolic pressure volume relationship, this point F here, lie on a different line, that lets you know that these differences that are occurring, they're due to differences in contractility and not blood volume, okay? So, when you look at each of these curves, you're going to see basically a change in cardiac function with changes in contractility. So again, if we have a normal operating heart here in black, and then there is a decrease in cardiac function, a decrease in contractility, such as, again, the case in heart failure. Maybe someone has had a heart attack or similar cardiovascular event, and there's fibrosis of the cardiac muscle tissue, and it's just not behaving and contracting the same. Again, what you see is that, we have this period of diastolic filling, and then we have a buildup in pressure and then ejection. And so you're really seeing this ejection phase, this D through F, there is less volume of blood being ejected. And you're also seeing, a reason for that too is because, again, the heart muscles cannot produce enough force, they cannot produce enough pressure to really eject that blood out. And so that point F right here, you see that decrease heading from normal control to a decrease in contractility. While if there's an increase in contractility, let's say, some sort of drug, some sort of inotropic agent, right? If we get an increase in cardiac function, well, what do we see? Well, we get an increase then of the amount of blood that is ejected from points D to points F. So this corner right here to the point F. So if you have that increase in contractility, you increase the amount of pressure that's generated, the volume of blood that's ejected. And so, in these conditions, you're looking at preload being constant. Decrease in contractility is going to decrease stroke volume, and that's because of the decrease in pressures that are generated here. And then when we have an increase in contractility, we increase stroke volume, again, because the heart, the cardiac muscle, is producing more pressure within that left ventricle, and that leads to greater ejection of blood out. And when you have an increase in contractility and stroke volume, well, then the ESV, this point F, is going to decrease, right? Less is left over in the left ventricle after the contraction, after this period of systole, because the force produced by the heart has gone up. Therefore, more has been ejected out, and less is left over after that contraction. We talked about preload, we talked about contractility. Now let's talk about the effects of afterload on cardiac function. We know that with increasing afterload, we really mean that we are increasing arterial pressure or aortic pressure, or basically the resistance to the left ventricle to eject out blood. And so if we see an increase in afterload, that's going to shift this volume pressure relationship up and to the right. And ultimately, then we're going to get a decrease in stroke volume as afterload increases. The opposite is true. If we decrease afterload, then we get an increase in stroke volume, right? And so ultimately, what you're seeing here is just purely changes due to afterload. We know that because the ESVPR, the end systolic volume pressure relationship, lines with on that same line. But ultimately, if you reduce the resistance to blood flow out of the left ventricle, well, then you get this greater stroke volume, right? But then if you if you increase the afterload, well, then you're going to reduce the stroke volume. And so, again, these aren't brought about by changes in preload. The EDV is the same for all three of these curves. It's the afterload ultimately that is impacting the stroke volume and then impacting the amount of blood left over after contraction, this ESV, right? So, less is being ejected from the heart with increases in afterload. Therefore, the amount of blood left over in the ventricle would increase. But if you decrease afterload, well, then more is ejected out of the heart, and then less is left over after that contraction period. Another thing that can impact the function of the heart and this volume pressure relationship is myocardial compliance. And so when you have a less compliant heart, you're going to see changes also in this volume pressure relationship. So to relate it in a way, when someone has a heart attack, right, what you're basically getting is a blocking of blood to the muscle surrounding the left ventricle. And ultimately, some of those muscle cells are going to die off, right? And so that dead muscle tissue has to then be replaced with something. So your body basically replaces it with this fibrotic tissue. So whatever area was damaged and then replaced, well, that area is no longer consisted of cardiac muscle fibers. Now it has this non-contractile, less compliant fibrotic tissue, than the undamaged cardiac muscle tissue. And ultimately, what that results in is a decrease in end diastolic filling. So we're going to see that EDV decrease because that tissue, that fibrotic tissue, is more stiff, less compliant, and therefore we can't fill up the left ventricle as much at the end of diastole, as indicated by this point C right here. And so ultimately, a reduced compliance shrinks the pressure volume loop. And so we, can see this whole point here from C to D to E to F, that is going to shrink. So ultimately, stroke volume decreases because of that reduction in end diastolic volume. Because of that decreased compliance. And so ultimately that is going to shrink, again, this stroke volume, shrink this curve. And again, we're assuming constant contractility. We know that, again, because both of these F points are the same. Therefore, they're on the same line. Therefore, we know contractility is constant in this scenario. So showing and just isolating alone what myocardial compliance does to this pressure-volume relationship. And ultimately, it decreases stroke volume due to this decrease in end diastolic filling. We know that changes in cardiac output are due to changes in heart rate and changes in stroke volume. So obviously, when there is an increase in heart rate, there's an increase in cardiac output. When there's a decrease in heart rate, there's a decrease in cardiac output. Now, the three factors that we discussed today, which affect stroke volume, are preload, contractility, and afterload. So if there's a decrease in preload, there's a decrease in stroke volume, therefore cardiac output as well. The opposite holds true. If there's an increase in preload, then there's an increase in stroke volume and cardiac output. We know that for a given preload, an increase in contractility increases cardiac output due to the increase in stroke volume. A decreased contractility would then decrease stroke volume and cardiac output. And then afterload has an inverse relationship for stroke volume and cardiac output. So at a given preload, a decrease in afterload increases the stroke volume, the amount of blood ejected from the heart, therefore increase in cardiac output, and then the opposite also true. Increase in cardiac afterload would then decrease stroke volume, decrease cardiac output. So ultimately today we talked mainly about afterload, preload, and contractility and its effects on the pressure-volume relationship and the effects therefore on stroke volume and cardiac output. Ultimately, when we have an increase in preload, an increase in contractility, we increase stroke volume. Afterload is going to have that inverse relationship. When we increase afterload, we decrease stroke volume and cardiac output. And ultimately, that's going to have impacts on our pressure-volume relationship as well. And then we sort of introduce myocardial compliance. Again, when we have, damaged tissue and it's replaced by more fibrotic tissue, and the heart becomes less compliant, this is also going to have an impact on this volume-pressure relationship and then therefore stroke volume. Thank you guys so much. I'll see you in the next video.